Hi everybody, welcome back. We are now in our second module, so hopefully first module was nice to you. You guys have a great understanding of some of those basic ultrasound terms. We're going to kind of roll right into some more of those ultrasound specific terms. This is my third time trying to record this module. My phone kept going off, my cell phone kept going off, my email kept going off, so hopefully I have silenced everything in my office. And if we happen to hear some nearby sounds, then just disregard those because I don't think I can record this a fourth time. But today we're going to be talking about some terms that we use to describe our image, to describe how we're scanning, and we use these terms to help us categorize and really to determine if what we're looking at is normal or maybe it's not looking so normal. Maybe it's falling into that questionable category of being abnormal. We're really going to start with kind of this overarching theme throughout the program where I reference things in two different ways. So I'll reference how we do things or how we learn things in either a clinical sense or a registry sense. When we're talking about some topics, I will often say in the clinical world, you want to do it a little bit differently than how I'm saying to do it in this lecture. I have to gear my lectures towards how the registry is going to test you. But in the clinical environment, in the clinical world, there are different ways of doing things and referencing things. So we're going to kind of start to see that with some of these terms today. So kind of keep your two different pathways of learning open. Now, we talked a little bit last week about acoustics. We just briefly talked about the term, and that's that scientific way of how we use sound waves and how we use the energy associated with sound waves to create our pictures. We're going to learn all about the science behind that, all about the physics behind acoustics, how sound waves behave, how we can manipulate our sound waves, all of that in our physics class in the spring. So we're not going to get too crazy with it, but we do have to have a basic understanding of just how speed travels in terms of, how sound travels in terms of speed. So we have what is called the propagation speed, and that is going to be the speed of sound traveling through a medium. Now, in the clinical ultrasound world, that medium is typically going to be soft tissue because we're using the human body as our medium. And we're giving that an average. So we're going to see 1,540 meters per second as our average speed of sound or propagation speed in soft tissue. Now, soft tissue is going to be talking about liver, kidney, spleen. All of those structures have pretty similar characteristics, pretty similar densities. So sound is going to travel or behave very similarly in those structures. And that's kind of why we give it an average for quote unquote soft tissue. Now, if we look at our chart here, we see that 1,500 range is going to fall into those brain categories: kidney, liver, muscle, fat. All of those, like we said, are very similar to each other. They're kind of soft, but they have typical densities to them. If you look all the way at the bottom of that chart, you're going to see bone. And if you look at that velocity, that propagation speed is going to be ridiculous. So we have 3,000 to 5,000 meters per second for sound as it interacts with bone. And that's because bone is so super dense that the sound has to travel really fast through that tissue to be able to penetrate through it. Now, we aren't able to evaluate bone on ultrasound because of that really high velocity. Clinical ultrasound machines, we are geared, we are manufactured to work best with that average propagation speed. So because bone in that sound wave has to travel so quickly throughout that bone, we aren't really able to evaluate it because of that. Same thing if you look at the top of that chart. We have air, and that's going to be where our sound wave travels really slow. So 331 meters per second for any sort of air-like medium. Now, this is why we also cannot evaluate the gastrointestinal system as well as we can other soft tissues in the body. Our GI system has too much air throughout it, and the sound wave does not know how to behave, typically traveling through that air-filled structure. So anything too low in terms of our velocity or our propagation speed, or anything too high in terms of that, is going to be where we're not falling in that clinical ultrasound range. So any soft tissue structure within that average propagation speed is going to be where we can get really great image detail, because that's what our manufactured machines are manipulated to evaluate. Again, anything too slow, anything too fast, we're not able to see it as well as we can or as well as we want to. So we said that we're going to be using some of these terms to help us characterize, and we're looking really to see, does this structure look normal or does it look abnormal? And how can we do that? How can we determine if something looks normal or not? We're going to learn all about what is considered normal for each specific structure as we go through this course and as we go through the program, but we need to know the terms that we associate with normal or abnormal for those structures. So how are we going to categorize a structure? Excuse me, characterize. You never realize how close those two words are to each other. So how do we characterize a structure? We look at that structure and we evaluate it on its own. So we look at its contents, we look at its shape, we look at its borders, we look at if there's any appropriate blood flow. So if an organ should have blood flow to it, do we see that blood flow? If we do, then great, that's normal. But if a structure shouldn't have blood flow, and we do happen to see blood flow in it, well, then we have to kind of question that further. So we're looking at the structure on its own, but then we're also looking at the structure and referencing its surrounding neighborhood. So how is that structure affecting the tissues or the organs around it? How is it having an impact on what is going on in that nearby region? We see a lot of malignancies that have an effect on nearby structures. It's typically a bad thing. Usually benign things or normal things are not going to have an effect on surrounding structures, or if they do, they're pretty minimal. They're pretty friendly. They're typically not invading nearby structures. So as we learn about each particular organ, we'll learn about what that normal and abnormal nearby relationship should be. How do we characterize a structure, or why do we characterize a structure? So like we said, to determine, is this normal or is this abnormal? Does this belong in the specific region? Does this have blood flow when it shouldn't, right? So these are all things that we're going to learn about as we go on, and we have to understand these terms that we're going to talk about to help us to determine if it's normal versus abnormal. So let's get into some of those typical terms. Like we said that we're using these to help us describe how our structures look. So the acoustic properties, those sound properties, or those characteristics of a structure or an organ, these are terms that we are using across the board. So if you're working here in Rhode Island and then you move out to California or Hawaii, you're going to still be using these terms. This is kind of that national radiology community that we are using. This is kind of setting that standard to be able to provide very similar care across the board on a national level. So these are all terms that you're going to see on your registry, and you have to get comfortable using this new language. So when you're first learning these terms, you're going to get them mixed up for a little bit, and that is anticipated. That is to be expected. So you have to kind of figure out any way that you can to get these terms down in your mind. So let's start with some of them. Our first one, this is termed anechoic. Anechoic is talking about any structure that does not have any internal echoes. Now, echoes, think of sound, right? This is kind of that root of that term acoustics. So acoustics, you have sound, it's going to echo throughout, right? So when we have a structure that doesn't have any echoes, it's not receiving any sound waves from that particular structure, it's going to appear all black. Now it says or dark on this slide, and this is going to be one of those things where your registry may say one thing, but in the community, in the radiology, in the ultrasound clinical world, anechoic has to mean completely black. When we're talking about terms getting into now more of a dark structure, that's going to have a different term to it. So anechoic means there are no echoes. That prefix "an," we're going to see that throughout the program, is going to talk about absence, the absence of something. So the absence of echoes, if that helps you to remember it. These are typically going to be fluid-filled structures. So benign fluid-filled structures should be anechoic. These are going to be caused because fluid-filled structures have low attenuation rates. Now you're probably thinking, I haven't heard the term attenuation up until this point. We talked about propagation. What does attenuation mean? As sound travels through the body, it slowly loses its energy, right? So think about when you're running a race. You typically have a lot of energy right when they say go. By the time you get 1 lap in, 2 laps in, you're slowly losing steam. That's going to be the same thing for our sound waves. Right when they come out of the transducer, right when they enter the body, they're going to be the strongest. As they travel through all those different layers of tissue, there's that energy slowly going to get absorbed by those tissues, and it's going to have a weaker signal as it continues to travel deeper into the body until unfortunately it gets to a certain level and there's no more energy left. Also, think of it like that flashlight, right? So the brightest beam of a flashlight is going to be right where it first comes out. And as that light radiates outwards to further distances, it gets weaker over that period of distance. That is what is talking about ultrasound with attenuation. So the further something travels or the thicker a tissue the sound has to travel through, the more attenuation is going to occur. Sound travels very easily through fluid, so it's going to have a lower attenuation rate. Less of that sound wave is going to be absorbed through a fluid-filled structure. So low attenuation structures are going to produce anechoic images, anechoic black appearing structures. Typically, these fluid-filled structures, if it's not a fluid-filled organ, it's going to be considered cystic. So although we don't give the term cystic to a structure, we give the term anechoic to a structure. Cysts themselves should appear anechoic. There are also some terms that are referenced with anechoic. Now, these may be registry questions, but we don't really use these in the clinical world. You're going to hear echo-free, echolucent, or sonolucent. Those are all synonymous with anechoic, but we're usually kind of just sticking with that term anechoic for black fluid-filled structures. So the bladder is going to be our prime example of an anechoic structure. It is fluid-filled, it is filled with urine, it is a low attenuation structure. Because it is fluid-filled, sound can travel very easily through it. The sound is not going to be as absorbed as it would be traveling through a thicker structure or a thicker tissue. So it is giving us a black appearing image. Next, we have echogenic. Now, echogenic does have some variations to it. You can have something that is hyperechoic, which we will talk about, or hypoechoic, which we will also talk about, and both of those are considered to be echogenic. This means any structure that is producing echoes. So anechoic, we said no echoes, nothing at all in those black structures. Echogenic is now that range of having internal echoes to it. So this is where we're going to start to get some shades of gray. So we're going to have structures that appear white or very bright on our picture. These structures themselves are producing the echoes. These are going to typically be higher attenuation structures, so a fluid-filled structure or organ is not going to be echogenic because a fluid-filled organ or structure is going to have a low attenuation rate. So these are going to be made up of some sort of solid tissue, something that has a higher attenuation rate than fluid. So this is also going to give us the term echoic, hyperechoic, and echo-rich. Now we said hyperechoic and hypoechoic are also both in the spectrum of echogenic. Echogenic is going to be that base term that we use for anything producing echoes. We typically use hyperechoic and hypoechoic more frequently than we do echogenic because it gives us more specific description of that structure. So once we talk about hypoechoic, that'll maybe make a little bit more sense to you. So give it a minute as we move through here. Our example on this slide is going to be a gallstone. So gallstones are very hyperechoic. They produce very bright white images, and they are very high attenuating structures. Next, we have complex. So this is when we have a structure that is both anechoic and echogenic, or has both anechoic and echogenic areas. This is typically going to be a mass of some sort. We don't have organs in the body that are considered complex on a routine basis. Typically, if a structure is anechoic, it is fluid filled. If it has a solid component to it, meaning it has an echogenic component to it, we need to question if that is a malignant structure. So complex structures, complex findings are typically not great if it is truly complex. So if we're seeing both solid and fluid components in an area, we need to question if that is a mass, and we need to further question that mass to say, okay, what is this? What's going on? Is this malignant? Because typically complex findings are going to be malignant. Now here, if we look at our picture, this is a breast mass. So we have our surrounding breast tissue, and then we have our anechoic portion here outlined in blue. So that's going to be the fluid component of this finding. And then we have our solid component here outlined in red. So this is all one structure, this is all one mass, all one finding, but that red component is what's worrisome. That solid component is what is questioning us to say, okay, is this a malignancy of some sort? Because I shouldn't see complex findings in the body. Anything that has a solid component to an overall anechoic finding is going to lead us to question that further. Next, we have isoechoic. So this is talking about the comparison of the echogenicity of one structure to a nearby structure, or maybe to a different segment of that structure. So this is saying that you have the same or similar echogenicity to a nearby or to a surrounding structure. So not necessarily the same texture, which we will talk about, but it's saying that you have the same shade of gray. Isoechoic. It is the same across the board. This is going to be really hard for us when we're talking about a discrete mass or tissue change. A lot of malignancies in the body happen very slowly over a period of time, and those changes can be really hard for us to see when the tissue is still the same shade of gray. So if we look at our picture here on the top, this is a side-by-side image of the right and the left testicles and the scrotum. They are two different structures, right? Because you have a right testicle and a left testicle, but they're displaying the same shade of gray. They are the same level echogenicity, so that means they are isoechoic to each other. Now, if you look at that picture on the bottom, this is a picture of the liver. Now, the liver should be the same color, right? The same shade of gray. So all of the tissue in the liver should be isoechoic to itself. But if you look at these arrows, they're pointing to an area where it has a slight change in texture, right? There's a little bit of a discrete border here. And this is actually a liver mass that is isoechoic to the surrounding liver tissue. So that's really hard for us to see when we're scanning, and that's where your precision has to come in. This is where we really start to train our eye to pick up on these subtle discrete findings, and we're looking at every piece of tissue in every structure, and we're really investigating it. And we're trying to say, are you the problem or are you normal? Next, we have echopenic. So this is not really the term that we use for this. This is something that we usually reference as hypoechoic, like we said before. Now, going back to that root word, we had echogenic, right? And that's talking about echogenicity. So the shade of gray means it's producing some sort of echoes. We're talking about some sort of solid tissue here. So when we have something that is really producing a lot of internal echoes, it's going to be hyperechoic, like we said on that previous slide. High attenuation structures are going to be hyperechoic, dense tissues, very bright white. Now, when we have a structure that's still producing echoes, but not as much as a hyperechoic structure is, it's going to be a darker shade of gray. So this is going to be our hypoechoic structure. It's still going to come from an attenuating structure, right? It's still going to be traveling through a solid tissue, but it's going to travel a little bit easier through that solid tissue. It's going to be a little bit more gray, and it's going to have a lower attenuation rate than that really hyperechoic structure does. So here we have a great comparison of the two terms. We have a side-by-side of our liver and of our kidney. Now this is a normal relationship. This is our liver here, outlined in red. We're cutting off some of those borders just because our liver is a very large structure that we can't fit it in our screen all the time. So there is our liver. Here is our kidney. Now, if you look at the two shades of gray between the liver and the kidney, the liver is a little bit brighter, right? It's a little bit more hyperechoic. If you look at the kidney outlined in green, it's a little bit darker. It's a darker shade of gray, so it's a little bit more hypoechoic. Now, depending on how you are comparing these two structures, your term would be different, right? So if you're talking about the liver is hyperechoic compared to the kidney, and the kidney is hypoechoic compared to the liver. So we're talking about the relationship here. We're using the term echogenic to say, yes, both of these organs are still producing echoes, but we're further comparing them to each other by either saying, yep, it's a brighter shade of gray, it's more hyperechoic, or it's a darker shade of gray, it's more hypoechoic. So next we're going to move into how we look at the internal composition of a structure or of an organ. We kind of touched upon it a little bit when we learned about isoechoic a few slides ago, when we talked about the texture of a structure and how it's not the same as echogenicity. So we're going to kind of delve into that a little bit more. So we're talking about the overall composition and the uniformity of internal echoes in a structure that produces them. So when we're talking about an internal architecture, do you think we're going to talk about it in terms of an anechoic structure? No, because an anechoic structure does not produce internal echoes. So we can't talk about the uniformity of echoes or the composition of those echoes because there are none. So when we're talking about architecture, we're only talking about echogenic structures. So our first term that we're going to talk about is homogeneous. So we're going to be talking about the word genius, and that is talking about the texture or the composition of the echoes within an echogenic structure. The prefix homo is going to mean the same. So we're going to have the same uniform composition and texture of our internal echoes in these structures. So this is meaning that we see the same shade of gray throughout, same echogenicity, same texture of tissue. So examples of this are going to be the normal liver, thyroid, and scrotal tissue. Here this is a transverse image of our thyroid, and we can outline this to show that we have the same shade of gray throughout all of this. Oop, kind of went over there. Throughout all of this thyroid tissue. The opposite of homogeneous, we have heterogeneous. So now hetero is meaning it's not going to be the same throughout. So we're getting different levels of gray, different echogenicities, different textures in this finding. Examples of this are going to be when our thyroid has some sort of disease or pathology. Abscess formations in the body have all different types of composition, so they're going to be considered heterogeneous, and any sort of metastatic disease or spread is typically going to be heterogeneous as well. So on that previous slide, we just showed a nice kind of uniform one shade of gray thyroid, and this is going to represent the heterogeneous version of that. So if we look at this thyroid tissue, it kind of looks like Swiss cheese, right? So that is all of those different echogenicities being represented, all of those different shades of gray being represented, and you can see it has a different texture to it. So all of these little hypoechoic little blobs, and then we have some hyperechoic little blobs in there as well. Those are all contributing to that thyroid being considered heterogeneous. Next, we have our texture. So this is talking about not necessarily the shade of gray, but it's talking about the spacing in between echoes within a specific structure. So usually we want to see our organs have a nice smooth texture, meaning that the echoes are spaced nice and tightly, very kind of similar fashion, kind of like, think about when military lines up and they're marching in sync. That's going to be that smooth texture of those echoes. They're behaving very similarly. They are aligned perfectly and very tight spacing. When we have echoes that are a little bit all over the place or a little bit different, maybe there's some sort of disease going on within that organ that's causing that tissue to be a little bit more spaced out, a little bit more irregular, so the sound doesn't really know how to travel through that tissue. That's when we're going to get our rough, coarse, cobblestone-like textures in an organ. So both of these pictures are representing liver tissue. On the bottom, we have our nice, normal, smooth liver tissue. All of those echoes are behaving very similarly. The echoes are very tightly spaced together. We're getting a nice, uniform, homogeneous liver picture with this. When we look at our top picture, this is still liver, but now look at, kind of cutting it off on our images there, but look at those spaces. So not only is this going to be considered heterogeneous because it has different levels of gray, different shades of gray within it, you can see that there's sort of a patchiness to it. It looks a little bit fuzzy. It looks a little bit kind of grainy, and like if you were to touch it, it would be probably rough for you to touch. So that's going to be that rough or coarse texture with a heterogeneous appearance as well. We're typically not going to see a homogeneous structure have a coarse texture. So homogeneous and smooth typically go together, and heterogeneous and coarse or cobblestone or rough are usually going to go together as well. Next, we're going to talk about through transmission. So we've kind of talked about how sound behaves in a structure. We also need to be aware of how it behaves once it travels through a structure. That can be really informative for us in terms of determining if something is benign or malignant. So this is going to represent how the sound waves travel through a structure, and we're looking at the area of our image that's directly posterior to that structure. Usually we're going to see things become either brighter in that posterior region, darker in that posterior region, or unchanged in that posterior region. So when we have an area that is brighter in that posterior region, this is how we term increased through transmission. So this is also known as enhancement. We typically use the term enhancement a little bit more than we do increased through transmission. It's just a little bit easier to say. And this is when our sound waves travel through typically an anechoic structure or a structure that has a very low attenuation rate. This is when our sound wave is still really strong traveling through that structure, right? We said low attenuation structures, they're not really going to absorb a lot of that sound wave. So that sound wave is still going to be pretty strong as it travels through and continues to move on into the body. So that's why it gets a little bit brighter behind these structures, these low attenuation structures. That sound is going to sort of get what we call written behind or posterior to that structure with a low attenuation rate. So here we have our anechoic structure here. This is actually a cyst. This is a fluid-filled cyst. It's anechoic, perfectly black, no internal echoes. Sound can travel very easily right through it. That fluid-filled structure is not going to absorb any of that sound. So that sound is going to continue traveling posterior behind it. It's going to appear very bright behind it. This is all our enhancement. Now, the opposite of that, we have decrease through transmission. This is also what we call shadowing. This is when our sound waves hit a very high attenuating structure, and that structure absorbs all of that sound wave, right? Attenuation means absorption. So it's going to absorb all of that sound wave or most of that sound wave, and it's not going to have any strength left to travel beyond that high attenuation structure. So this is typically going to occur when our sound wave hits either bone or hits a calcified structure. So our gallstones, like we used in our previous example of a very hyperechoic structure, the structure themselves is very hyperechoic, it's very bright white, it has a very high attenuation rate. That high attenuation means it's going to absorb a lot of that sound wave, and posterior to that sound wave traveling through that gallstone, it's not going to be able to produce anything behind that for our image. So that's where we get our shadowing from. So here, very hyperechoic, high attenuation gallstones, calcified structures, sound wave hits them, going to be very absorbed by those gallstones, and posterior to those gallstones, we get all this shadowing. We're not getting any helpful information posterior to those gallstones. So it's kind of just like a blackout right in that region. Okay, so in conclusion, with all of these basic terms for image description, we want to make sure that we're using them to be able to give a full evaluation to every organ that we're looking at in each particular exam. You have to have a strong understanding of what these terms mean and why these terms are given to these specific findings on our picture. We have to be able to pay attention to the details. Think of that isoechoic picture with that liver mass, right? Probably did not see that, and especially if it didn't have yellow arrows pointing to that liver mass, we really wouldn't have seen it. So you have to make sure you're really going through each individual picture, each organ, each little piece of tissue with a fine-tooth comb to make sure you're not missing those small discrete details. And make sure you take your time. When you're scanning, these things take a lot of practice, a lot of hands-on time. So it's not something that I want to see you guys be frustrated with right off the bat. This is something that you are going to learn over time. We're going to practice, 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 and you will have a good understanding of these terms and how to apply them to your own individual scanning skills. So I want to go through some examples to maybe see if you guys can take a minute to yourself to use these terms, I guess. So let's use some different dog breeds for us to practice. So here is actually my dog Lincoln. This picture was from a few years ago. He's an old man now. He's about 10 years old, and he's still crazy because he's a Jack Russell. So we're going to use his appearance to categorize him. So he has both black and white areas on his fur, right? So black, we know, no internal echoes, anechoic, but white, that's typically going to be echogenic. So that means he is going to be complex. He does have uniform spacing of his fur, right? If you look at his fur, very smooth, very close together, very similar, from his ears down to his tail, all the same texture. So he's going to have smooth texture. He is black, white, and spotted. So he's going to be considered heterogeneous, meaning he does not have the same shade of gray throughout. So that's my little guy Lincoln. This cute little poodle here, he is the same quote-unquote shade of gray, or in his case shade of brown. So he's going to be considered homogeneous. If you look at his fur, it's not the same throughout his whole body, right? His snout fur versus his ear fur versus the little curly cues on the top of his head, those are all different. So he's going to have a coarse texture. And then his snout fur is going to be considered isoechoic to the rest of his body, right? He is the same shade of gray throughout. All of his different regions are very similar in terms of echogenicity, although he's not very similar in terms of texture. Next, we have this big guy. So this is kind of like looking like a lion over here. He has slightly different shades of brown fur. So if you look at his snout fur versus the fur color around his eyes versus his mane fur color versus his ear fur color. They're all slightly different from each other, right? So they're not the same shade of quote unquote gray. So he's going to be considered heterogeneous. He does not have uniform spacing of his fur, right? The fur on his snout is very different than the fur on his ears, than his mane, than the fur down here near his tongue. So he is going to have a coarse texture as well. He has some wildly spaced furs. And then again, his snout fur is going to be considered hypoechoic to the rest of his body fur. And then this little guy here, this looks like some kind of like, I don't even know. Some dogs don't even look like dogs in my opinion. But he has black fur and he also has echogenic or lighter fur. So he is also going to be considered complex. His light brown fur is going to be termed hyperechoic to the dark brown fur around his face. He does have anechoic, hyperechoic, and hypoechoic fur. So here is his anechoic fur. Here is his hypoechoic fur, and here's his hyperechoic fur. So he's going to be heterogeneous. His fur is not evenly spaced either, so he is going to have a coarse texture. And then this cute little baby pitty, so just thinking cute. He is both hypoechoic and echogenic, so he is going to be heterogeneous. Now he's not considered complex because he does not have any black fur, right? So he is a shade of gray and also white, so he is heterogeneous, and his fur spacing is all the same throughout his whole body, so he is going to be considered a smooth texture. So hopefully this helped. Please use this information to help with our next PowerPoint that we're going to go over in this module. If you have any questions about this, please make sure you stop and send me a quick email before you move into our next PowerPoint, because that's going to take things a little bit further. So please do not hesitate to reach out with any questions.